So how are you? Do you feel that the burden or responsibility is a bit lighter during this second phase?
Um, I do hope the difference will happen, but I also see that at the moment everybody is kind of feeling relaxed and ready to go out and kind of putting themselves at some kind of risk. But I think at this time, although people relax, but I believe that the level of risk is not that high at the moment. But I still hope that there will be something to remind them that this is not the time to relax everything yet.
I see. So, Dr. Tanarak, for 3 consecutive weeks now, we have been having the new infection cases on the lower end of the 1-digit figures, right? Of course, we should be happy that the trend. But what does the trend tell us? If the figures, continue to be like this, 2-3 cases a day, what does this trend tell us?
The trend is one thing, and we can say that recently, although we have a few cases report every day, but the number is quite very low, and is maybe stabilized at this point for a few moments to come. A few days to come. But there's one truth that is, if you remember a few days back when Dr. Thuy also mentioned about 3 scenarios of what will happen in the futures. I'm not going to talk about those 3 scenarios, but I would like to remind you that when he said about the situation in the past, there are 2 lines. One line is the number of true cases that we expected in the countries, and the second line is the number of cases we got the report. And those line is very much different. What does it tell us? It tells us that at any point in time, there will always be someone who was infected with COVID-19, but will not go to the hospital and will not be diagnosed and will be. So at any point in time, we will always be underreported of the true number of COVID case, always. At these times, although we have very small numbers, 2 cases, 1 cases, some days we have no cases. But in reality, there may be somebody who is currently infected with COVID-19, but because he did not know that he was infected, because probably he doesn't have much of the symptoms, so he stay back, he stay at home, and he's still going out to work every day. This kind of cases that will make the situation continues. We still have. That is why we still have a reported case here and there every now and then. The situation like this happen all over the place. We can hear it from China that in certain areas where there were no cases for quite some time, and all of a sudden there were a few cases reported. Those are the same reason, because the symptoms is very mild and someone do not really know that he is infected, so he did not show up at the hospital and did not diagnose. So we undercount the number of cases at any time.
So that means that we should not be surprised if, say, tomorrow there will be, say, 10 cases of new infection. Is that what you're suggesting?
If 10 cases, that even me, I'm going to be surprised. But if there were, if there would be a few cases, 2-3 cases, that will not be surprising.
Okay.
So what do you reckon the strategy to be coping with this mild or asymptomatic group of people? What would be the strategy to cope with it?
There's only a few strategies that we can do. The most important things is what we call trying to detect the case as soon as possible and using 2 strategies. One is doing active case finding, and the second one is doing what we call surveillance. Active case finding is we are going out in the village, in the public places, using the epidemiological data, use the past data to identify the areas, the village or the factories um, or the place where we would expect that there may be some cases left over. For example, in Yala or in Phuket, where they identified some village that they saw a cluster of cases, so they went out and doing the survey of the whole village. This should be guided by our data. We should not go out and doing active case finding by just random because we are not going to identify many cases anyways, because at the moment we have very low prevalence or very low number of cases in the countries. That is the active case finding. We use our old data to identify where should we go out and do a lot of testing. The second strategy is what we call surveillance. Surveillance is for the patient who walk into the hospital but probably do not identify themselves as having COVID. For example, if our healthcare workers show up with any symptoms of acute respiratory illness, we are going to test everybody, every healthcare workers, no matter how mild the disease he or she has. The second group is probably any patient who show up with ILI or influenza-like illness. Influenza-like illness is basically the same thing as COVID-like illness. Have fevers, cough, sore throat, or rhinorrhea, or difficult breathing. Anybody who show up with this, we should randomly test them for COVID-19. At the moment, I don't think we can test everybody yet with the capacity of laboratories that we have at the moment. Those are the reason why we should randomly select the ILI patients for testing for COVID-19. But if we have more capacity for testing, we can expand the testing to more people. The other population that we should do the testing was patient with pneumonia. All patients with pneumonia should be tested for COVID-19. The list can go on and on. Another population that we are planning to do surveillance for COVID-19 is a cluster of influenza-like illness or COVID-like illness that occur in any settings, in the closed settings. For example, in one village, in one school, one university, or in one department store. If we found the cluster of common cold, we can go out and investigate and do testing on the staff who work there. Those are the two strategies, different strategies, but we can use those strategies to identify COVID-19. If I may, I would like to also tell you that there are also different surveillance schemes that we are implementing. For example, we are counting the percentage of COVID-like illness that present at the hospital at any days. For example, if one single hospital today has 200 outpatients, how many of them has acute respiratory illness? We are going to collect those data and analyze, because if there is a COVID outbreak, this can be shown very early with COVID-like illness. The second is we are going to count number of pneumonia cases that is increased or over time comparing to last year or the years before that. The other things that we are also implementing is that we comparing the number of deaths this year with last year and the years before. The reason we also count number of deaths is because recently we have seen the report of COVID presenting with different kind of symptoms. For example, people come with deep vein thrombosis, or having a stroke, or having different presentation, not just only pneumonias. That is why we are planning to count on the number of total deaths that we have reported currently as well. So there are several ways that we can try to identify the areas or try to identify who we should be tested for COVID-19.
Dr. Tanarak, the Education Ministry hopes to have schools reopen on the 1st of July. And of course, there has been pressure from parents and some other groups in the society for the schools to reopen even sooner. And today, there is a note of caution from Dr. Yong Puvarawan, the well-known virologist who warned that the timing of the reopening of schools should not be made as a political decision, but should be made on scientific reasoning or scientific data. So what is your view on this?
I can understand the situations because when the school is closed, there is a lot of pressure on their parents or their caregivers, and most of Thai now is both parents is working full times. So if the kid is still at home, there will be problem to their parents. But the truth is that there will be a risk at some level to put our children back at school in the same ways that we used to do, because our school, most of our school, not every school, but most of our school are very crowded. In some classroom, there are more than 40, maybe 50 students in one single rooms, and they sit very close to each other. Those are the perfect situations for COVID spreading. So what we should do is that we should try to understand this issue. And the other thing is that the symptoms in most of the children is very mild. Because of that, any kind of screening, temperature screening, or even cough observation for cough will not help the school that much, because only less than half of those children who get infected with COVID will show up with those symptoms. So at most, doing a great screening can screen only about 50-60% of infected children entering the school. That means there may be 30-40 or even 50% of COVID-infected students that can enter the school, no matter how good the school system for screening would be. So what does that mean? It means that at any time, if we are not aware, the COVID can spread in the school very easily, and without anybody noticing that there is COVID outbreak in the school. I say this will be a silent outbreak. It will not affect the student that much. I mean that the student will not have a very severe diseases. But if they go back, or even if they are at school, the one who will be at highest risk will be the school teachers, who also have a very close contact with the student. And when the student go back home, another person who will be at very high risk of getting infected and probably getting the severe disease is their parents and probably their grandparents if they live together with the elderly. So our quick thought would be that the school may be reopened on schedule, but the ways that the school operate should not be the same. The student should sit further from each other, at least 1.5 or 6 feet or 2 meters from each other. So you can imagine that one single room may fit only, usually will fit only 20 students at most, not 50s. I'm sure about that. So the school will have to find the ways to operate differently from what they used to operate. They may have to have students come in some days, not every days, probably 2 or 3 days a week. And I will suggest that students should come back into school no more than 3 days, or probably 2.5 days.
I see.
So all the rules that apply to department store, apply to the restaurant, apply to other settings, must also apply to the school as well. The student cannot sit next to each other. They also have to wear masks at all time, and the school must have a good screening system, good surveillance system. There are a lot of things that school should prepare very, very early, and they also have to find a ways to teach the student when they are not at school. And I think using these hybrid ideas, that is mixing between long distance and also coming to school to study, will help ease the education a little bit, and also will help ease the parents as well. So that is why I always said that work at home and learn online or long distance learning has to go together, because if you are not having the student at school every day, then the parents should be able to stay at home with their kids also. So the policy of long distance learning have to go along hand in hand with the policy for work at home, for both government settings and also private settings.
And so far, Dr. Tanarak, I'm sure you must be quite aware of the measure in Sweden of having no lockdown, but having the population be responsible among themselves and try to respect social distancing and wear face masks whenever they can. Do you think this practice should happen in Thailand at this very juncture? Would it be probable for people to develop immunity automatically?
The system, the healthcare system and the public health system in Sweden and in Thailand are not comparable. Sweden has a lot more doctors, a lot more hospital beds per population when comparing to Thailand. And their population density is very low. Sweden has, if I recall correctly, just around 10 million people living in Sweden. So all of this, and also they are a very well educated population. They usually follow the instruction from the public health personnel very, very well. The cigarette smoking rate is very low. If I'm not mistaken, the cigarette smoking rate is lower than 10%, single digit smoking rate, and it's going down very constantly. And the government do not have to do anything. In Thailand, we have Thai Health Foundation with a lot of funding, but still we still have a lot of smokers in Thailand. So the health system is not comparable. They are developed countries with a lot of resources. The population is different, and the ways they react to the situation is also very different. I still believe that we have to be very cautious at all time. When we compare ourselves and very well developed countries, I don't think the situation in the countries can compare with us. For example, if we have, let me give the numbers. For example, if we have about 100 cases per day, very soon our hospital may be jam-packed with all the patients. But in Sweden, I think they are still fine for them, because they have so many resources, many hospital beds for all the patients that they may have. So that is why we have to be very cautious at all time, because in the past we did not invest in the healthcare system that much. We have lower number of doctor per population. We have lower number of hospital bed per population when compared to most of the developed countries. So that is why we have to do what we have to do today.